Today we are going to discuss about two diseases which are very similar in appearance and which are very common. One is hand-foot mouth disease, otherwise commonly known as HFMD, and other one is herpangina. So HFMD is characterized by, it's a clinical syndrome basically. It is characterized by oral ananthema, that is redness, along with either macular, maculopapular and vesicular rash over the hands and also feet. And herpangina on the other hand is a benign clinical syndrome. It is characterized by oral ananthema as well as papillovesicular ulcerative lesions seen in the mouth. So it's also characterized by fever. And what causes it? So herpangina as well as HFMD are caused by most commonly by Coxsackie virus A16 and enterovirus 71. There are various other subtypes of Coxsackie, echo as well as enteroviruses which can cause both HFMD as well as herpangina. So how is it transmitted? Humans are the only known carriers for HFMD. It is transmitted either through fecal-oral, oral, oro-oral or through droplet contacts, and the child is most infectious during the first week and later, but however in the stool the virus is shedded for nearly 6 to 8 weeks. So what is the pathogenesis? So once this oral ingestion of the virus into the GI tract, either from respiratory droplet or through direct contact or from the vesicular fluid, so they multiply in the submucosal lymphoid tissue of the intestines, pharynx as well as the lymph nodes. During this replication, they lead to something known as minor viremia. From here, they travel through the reticuloendothelial system to multiple different organs where they again multiply and they cause secondary viremia or the major viremia. So this is the pathogenesis in general. So what are the clinical features? So we will see the clinical features of HFMD as well as herpangina. For HFMD, usually it starts as a very low-grade fever, malaise, sore throat, and they will have usually painful oral ulcerations over the posterior part of the oral cavity, and they may be either maculopapular or papillovesicular lesions over the hands and the feet. Usually the skin lesions are around 2 to 6 mm. They are either vesicular or ulcers. They usually enlarge and they have a surrounding erythematous halo, which is a red colored circle surrounding these lesions, and the distribution is usually over the hands as well as the feet, and sometimes there is a atypical infection which may be caused by Coxsackie virus A16, where unusual areas may get involved, the trunk, genitalia and even distal part of the extremities, and they even present with pain, fever, dehydration and desquamation of the distal parts of the hands as well as the feet. And there may be also nail matrix arrest, which is either seen as a transverse lines known as a lines, or there may be nail shedding, which is otherwise known as onychomatosis. So these are the different presentations of HFMD. And for herpangina, usually it presents with high grade fever which usually lasts for nearly 1 to 4 days. Then there will be sore throat, there will be dysphagia, and there will be lesions which are usually present over the soft palate, uvula, and the anterior tonsillar pillar, posterior pharyngeal wall, and sometimes even the posterior part of the buccal mucosa can also be involved. Here, in older children, the herpangina can be even present with headache, backache, vomiting, and severe abdominal pain. And the skin lesions in herpangina are usually 1 to 2 mm. They are either vesicles or ulcers, which later they enlarge to become nearly up to 4 to 6 mm. These are surrounded by an erythematous halo which extends up to more than 10 mm in size, and usually these are more than 15 in number. But what we clinically see are at any given time they are usually more than 5. The skin lesions in HFMD are usually resolved within 7 to 10 days, whereas in case of herpangina, it usually resolves within 3 to 7 days. And coming to diagnosis, the diagnosis of either HFMD or herpangina is usually clinical. If at all, if we need to isolate the organism, either we have to take a stool sample because the virus is shedded in the stool for nearly up to 6 weeks, and but in the pharyngeal part, it usually presents less than 4 weeks. And isolation further, we can take either cell culture, polymerase chain reaction, or we can take scrapings of the vesicles and or the biopsy part and to be seen under the light microscopy. This also helps in differentiating it from other vesicular lesions like herpes simplex as well as varicella zoster, where they have something known as multinucleated cells or giant cells. So this differential diagnosis, because the clinical picture is somewhat similar between Herpangina as well as HFMD, we need to differentiate it from other vesicular lesions like chickenpox, herpes simplex, herpes gingivostomatitis, Stevens-Johnson syndrome, and you have aphthous ulcers, measles, and erythema multiforme. So what is the treatment? The treatment part in either HFMD or Herpangina is the pain part we have to take care. Either we can give NaCIDs. The fever part we have to take care, and you have to properly hydrate the child. Admission is required if the child is too ill to take orally or if he is having extreme pain and he has signs of dehydration. So what is the prognosis? The prognosis in either HFMD or hyperangina is quite good. The lesions usually resolve completely within 14 days. So what are the complications we can expect in either hyperangina or HFMD? Usually there are certain viruses, particularly the enterovirus 71, which may lead to complications in some patients. Persistent stomatitis making the child difficult to eat, and they can be CNS complications, particularly with enterovirus 71, like brainstem encephalitis, like rhomboencephalitis, cerebellar ataxia, and they may be acute flaccid paralysis. They can be Guillain-Barré syndrome, and they can be benign intracranial hypertension, and they can be pulmonary complications like pulmonary hemorrhage, interstitial pneumonia, myocarditis, and even pancreatitis is also described. So, what is the prevention? There should be proper hygiene, should be maintained either before and while taking care of the sick child. The disposal of the diapers, and particularly the small infant, should be carefully handled because the virus is shed in the stool for more than 6 to 8 weeks, and there should be proper disposal of waste. Avoid close contact with the infected person, and sharing of utensils is usually not recommended with the patient and as well as the carriers. So this is about HFMD and Herpangina. So the both HFMD and Herpangina most common in the school age children. So you should be quite careful. If your child is suspected to have HFMD or Herpangina, kindly contact the nearest possible physician so that he can take care of the pain, fever as well as hydration and for early detection of complications. Thank you.